So with this, I hand over for the first talk to Professor Michael Stewart, who's going to talk about the aflibercept in abundance, sustained disease control with 8 milligram.
So good morning. Thank you, Dr. Dogra, and also thank you to Bayer Asia Pacific team for inviting me. It's certainly my pleasure to talk in this diabetic macular edema symposium. And let's see if I can get this to work here, my financial disclosures. And really, despite the fact that we and our patients have really been the recipients of excellent advances in anti-angiogenesis development over really now the past 20 years, we still have significant unmet needs with respect to the treatment of patients with diabetic macular edema. We've been very fortunate over the last, in the United States, 13 years, that we have aflibercept 2 milligrams, which has really become the agent of choice in many of the countries throughout the world. And we've not only seen great results with respect to DME treatment from Vivid and Vista, but we also have real-world clinical trials that have shown it to be effective and safe. And here are some treat and extend trials coming out of the Asia Pacific region from Taiwan, South Korea, and Japan, all of which show excellent disease control, improvement in visual acuity, and good extendability over the course of 1 and even up to 2 years. And we've seen that aflibercept 2 milligrams has really had an excellent safety profile when used around the world, with currently more than 84 million doses given since its launch. Nevertheless, we are facing an epidemic in diabetic macular edema, which parallels the epidemic we're seeing in the increase in number of patients with diabetes. And so we're challenged because treating patients effectively and having them maintain their compliance is going to be more difficult, especially when we keep in mind that the average diabetic sees over 25 medical examinations per year. We are one component of that, and trying to make sure that patients comply with their ocular treatment is going to get ever more difficult as treatment for diabetic care gets more sophisticated. Groups from around the world almost unanimously agree that reducing patients' treatment burden is probably the single greatest unmet need. This data from your retina shows that over time, we've become even more cognizant of that, with a majority of physicians actually saying that we need to reduce the treatment burden. And the burden is not just on us and our practices and offices, but on the patient having to come in repeatedly, on the patient's caregivers, as they have to take time off work. And in fact, if you look at data out of the US, about half of the money spent on diabetes care is actually not direct care. It's actually the indirect costs associated with getting patients to and from clinic visits, lost time at work, and taking care of patients who have diabetes-related disabilities. And so really what we need is greater and longer-lasting disease control through sustained disease control. So how can we do that? How can we improve current anti-VEGFs to achieve sustained disease control? Well, if you put yourself in the mind of a drug developer, there are several factors you're looking at as to try to create a new drug or improve a therapy that's already been established. And here are 5 of the major pharmacokinetic contributors to how well drugs work. Binding affinity and potency on the left really talk about how well the drug binds to its target ligands and then inhibits either free ligand within the space or VEGF-mediated processes. On the right-hand side, you have molecular targets, and then lower right is molar dose and ocular clearance, which we'll talk about in a little bit more detail. Aflibercept has really had a very attractive pharmacokinetic profile with high reported potency, the highest binding affinity of any of the anti-VEGF-A drugs, and the most diverse range of molecular targets, not only VEGF-A isoforms, but also placental growth factor, VEGF-B, and galectin-1. And we know that the key driver to angiogenesis problems is really VEGF-A binding through VEGF receptor 2. That then dimerizes the receptors and increases all of those downstream effects that we see with angiogenesis. But working in parallel with that is receptor 1. And though VEGF-A binds to receptor 1, so does placental growth factor. And so we think that may contribute in some way to the angiogenesis effects that we see. And only by binding placental growth factor do we really inhibit all of the VEGF-mediated angiogenic processes, namely inflammation, neovascularization, and breakdown of the blood-retinal barrier, which of course contributes to macular edema. So how can we improve drugs? By binding to new targets, by creating drugs with different pharmacokinetic profiles, or if you will, by creating a new drug that's based on an excellent safety profile and gives us new pharmacokinetic characteristics. So if we go back to aflibercept, we have this 13-year history of excellent sustained disease control with a beautiful safety profile. How do we make it better? Well, we changed the drug, and in doing so, we increased the molar dose. And that's what aflibercept 8 milligrams was designed for, was quadrupling the dose, theoretically extends its durability within the eye by about 2 half-lives, or anywhere from as little as 14 to up to about 22 days, depending on what half-life we use. But what we found, what was interesting, was not only was the molar dose increased durability, but a little bit unexpectedly and quite fortuitously, we found that the clearance of the drug was actually decreased by 34%. So not only do you get extended durability by adding more drug, but the drug stays in the eye longer and leaves the eye much more slowly. And we found that from pharmacokinetic modeling that we think that it has the ability to inhibit VEGF by anywhere from 6 to 8.9 weeks longer than we see with the 2 milligram drug. And so we have to ask the question now, how might this help our patients? Well, most patients are treated on a durability basis according to sort of this bimodal distribution. And so can we help the patients on the left who require frequent injections by shifting the curve to the right, decreasing the number of patients that require injections every 4, 6, or 8 weeks? And we know from clinical experience we're not going to get those patients generally out to 20 or 24. But if we can increase their durability from 6 to 10 weeks, that's a major win, both from our perspective as well as the perspective of the patients. And then secondly, how about those patients that we're treating on 12 to 16 weeks, which historically we've thought were actually quite successful? Well, now with new durability, we can extend them out to 20 and 24 weeks. That's part of what we'll talk about today with respect to the PHOTON trial and the number of patients that actually get durability at the 20 and 24 week marks at the end of 2 and now with our 3-year data. And so really what we're looking at is sustained disease control by taking an existing industry-leading drug and making it better by creating the 8 milligram dose, and doing that by keeping in mind that we're doing it with a very comparable and excellent safety profile.